Okay, my name is Dan DeMaio. Hi, I am an educator. I work out here in Connecticut at the University of Hartford, where I'm a program director for radiography. I'm also a volunteer for the ASRT, and I'm currently serving on the board of directors for the ASRT. I am a speaker of the House of Delegates, and one of many volunteers for the ASRT. Hopefully, y'all are excited about either being a member of the ASRT already or joining the ASRT soon. What Christy was talking about is we have a national election going on right now, and I'm completing my 4th year on the board, my 2nd as Speaker of the House, and I'm now running in a national election for the position of Vice President. So thank you, Christy, for that nod. Can I just turn the attention to y'all for a second? I mean, first of all, the student committee, I mean, what you are doing here is just so incredible. And I know I've told you that already when we chatted recently, but it's gaining and garnering national attention. I mean, this is really a big deal. I think it can serve as a model to other states and other student groups in those states. It really is just fabulous, and just makes me happy and proud. Y'all are the future of our profession, and that future is looking pretty bright from what I'm seeing here tonight. So thank you for all that you're doing with this committee. Thanks to everyone for coming out tonight. And yes, I can see the chat. So there are going to be moments during tonight's presentation where I'm going to hopefully ask you to give me some comments about what we're talking about. And what we are going to be talking about, of course, is patient shielding. Those of you that are in your radiography program right now, you know shielding historically has been a very big part of our efforts to keep our patients safe, a basic tenet of ALARA, right? As low as reasonably achievable. What's interesting about ALARA is that it wasn't designed really to be applied to patients. It really was an acronym that was used and developed to keep occupational workers safe. But over time, it has certainly been adopted to be applied to our patients. And again, patient shielding has been a big part of those efforts to keep our patients safe. What's also interesting is you've come into the field at a pretty unique time. If you started your program this past fall, or maybe the fall before, you have entered during a time where the practice of shielding has already changed. But I'm very curious to learn tonight about what you've heard from your instructors, and more importantly, what you've heard and seen from the technologists that you've been working with at Clinical. Have they been talking to you about shielding? Have they mentioned how things have changed? And how is that change being implemented at your clinical site? So hopefully we'll have some of that discussion tonight as we move ahead. And basically, we want to talk about a little bit of the history of what has happened really now it's almost 4 years ago that we had this suggested change in patient shielding. And a couple of questions you see there on the screen that hopefully we'll try to answer together. So, because I'm a college professor, I'm obliged, I guess, to have a slide with objectives. I'll give you just a second to kind of read through those so I can take a sip of my tea here. All right, so that's a lot. We only have about an hour, maybe a little less to spend with each other this evening. So maybe we can look at the next slide to see what are a set of more realistic objectives. Again, definitely want to review the history of this change in shielding practice a little bit, but really also talk about the parameters. What I mean by that is the limits of this change and what it was designed for and how we're supposed to be implementing it. I'd love for you to appreciate the idea that no longer shielding the fetus and gonads during some radiographic procedures is a good idea. It's based on good science and it makes good sense. And hopefully we'll also, you're going to help us and the profession remain open-minded about this change so that you can help the technologists that you're working with. And then I'm really excited to talk to you a little bit tonight about the ASRT Patient Shielding Task Force that I've been really honored to work in and with. And I'll show you some of the work that we've been doing over the past few months. So let's just jump right in. And here is the audience participation portion of the evening, at least the first one. I would like you in the chat, if you don't mind, is to answer the questions that I have up on the screen. Are you still shielding patients, or are you shielding patients, right? Because you haven't been at this for too long. Are you shielding all patients, some patients? How do you decide who to shield? the technologist that you're working with, and the institution that you are completing your clinical work at. What is the policy there? So Sadie, thanks. Depends on patient's age. Thanks, Carrie. We've been told yes, because the ART exam says to. Okay, good. We'll touch on that a little bit tonight. That's great. Thank you, Minu. I shielded every patient except geriatric patients. Okay. Yeah, radiation therapists rarely do any shielding. Of course, Danny, thank you. Carl, what we're focusing on tonight really is diagnostic radiography. Shielding in CT is really not the norm anymore for reasons, if we have a chance at the end, maybe we can get into. But the change in practice we're talking about tonight is specific to radiography. Okay, Caitlin, that's great. If I am able to shield without obscuring anatomy, I do. Awesome. Thank you, Jacqueline. Okay, good. So keep those comments coming. If I get a chance later, I'll review them as well. But really important, I think, for us to share what we're seeing at our varied sites as well. We can learn from each other about what's going on out there. But thank you. Yeah, keep those comments coming. Okay. So I think this is a good place to start. And if you have already taken a radiation protection or radiobiology course, you are probably familiar with the diagram that you see here on the slide, the linear non-threshold theory that relates ionizing radiation exposure and biologic risk or biologic response. And it's this relationship that really serves as the basis for the as low as reasonably achievable, or ALARA, concept. And basically what it says is that all radiation dose carries some risk of harm. And accordingly, we have to make every effort to try to minimize that dose, to minimize that risk. And the most important thing that the LNT, or linear non-threshold theory, tells us is that there is no safe dose. So basically what that means is any dose, no matter how small, carries with it some risk of cancer. And the higher the dose, the higher the risk. So pretty straightforward. So our jobs then, of course, are to produce diagnostic, high quality medical images while keeping that dose as low as possible, right? So in order to keep that dose as low as possible, we employ some basic core concepts of radiation protection, right? We try to limit the time of exposure, and that's both to our patients and to us. We try to maintain distance from the source of radiation. Now, that's not always possible. It's definitely not possible with our patients, right? Because you're acquiring radiographs at some set distance for SID. But occupationally, we're definitely wanting to use the inverse square law to move as far away from the source of radiation as possible to limit our exposure. And then when that distance, if you can't maintain the distance you would like, let's say, then you would wear shielding. Right, occupationally for sure, but we've also used shielding in the past to protect our patients, and currently still. So it's really important to keep in mind this linear non-threshold dose-response relationship as the basis for all of our radiation protection efforts. There is lots of science out there that demonstrates very clearly that shielding the gonads during radiographic procedures does reduce dose. And this is a really famous one in our profession, and it was put forth by really just a superb educator and researcher, Dr. Terry Fauber. And if you kind of read through what's on the slide there, you'll see that Dr. Fauber demonstrated nearly 35% reduction in male gonadal dose during an AP pelvic radiograph. And you see the image up on the upper right-hand corner. So that's a type of cup shield that was back when I trained, 35 years ago, we used all the time. It's sort of like an athletic cup that if you've played a sport, contact sport, guys, you may be familiar with wearing one, but it's a lead impregnated rubber cup that we would actually place over the male gonads during pelvic radiography. And Dr. Fauber demonstrated that this type of shielding is actually very effective and resulting in a significant reduction in dose. But I want to take a little bit of a deeper dive into Dr. Fauber's study. And to do so, I think it's really important for us to first look at some math. Let me back up for a second and make sure I'm keeping everybody with us. So just look at that conclusion real quick, right? Where Dr. Fauber concludes that shielding the male gonads during a pelvic radiograph is still a best practice. All right, so I'll go back forward. So we'll do just a touch of math here, just briefly. Don't worry. We're not going to dive too deep into the math tonight, but I wanted to make sure we're all on the same page with regard to the units that Dr. Fauber used in her study, because it's really important for us to sort of critically analyze her results. If you remember, the gray is the unit of absorbed dose. And when we have that prefix milli in front of gray, that means 1,000th. So the small m, capital G, small y, milligray, is actually 1,000th of a gray. On the second line there, we see that funny looking U, stands for the micro or microgray. And a microgray is 1,000th of a milligray, so even smaller. Therefore, 1 microgray actually equals 1/1,000,000th of a gray. Again, gray, the unit of absorbed dose, and a full gray of absorbed radiation dose is quite a large amount. But when we're talking about microgray, we're in units of 1/1,000,000th of a gray, rather small. And why I'm pointing that out is, again, Dr. Fauber demonstrated nearly a 35% reduction in gonadal dose. But let's look closely at the numbers. Without the shield, the gonadal dose was 254 micrograys. Again, a very, very small amount of absorbed dose. When the shield was added, that gonadal dose dropped down to 186 microgray. That's a significant reduction, again, nearly 35%. But the bigger question we need to be asking ourselves is there any risk associated with dose that is this low? And that's a really important question, because it's one of the underpinnings or the reasons why we have seen this recommended change in gonadal shielding practice. And that change, the suggested change in practice, comes to us from the American Association of Physicists in Medicine. And we're going to look at their policy statement in just a couple of minutes. But what they're basically saying to us, if we tie it to Dr. Fauber's study, is, that is already a very, very low dose of radiation, for which there is very likely to be no risk of biologic harm. At least that's what the AAPM is saying, because they're relying on the data out there, and there's a significant amount that states that there's no evidence of carcinogenic effects for doses less than 100 millisieverts, right? That milli is a bigger number. So we're talking there about a pretty large effective dose, for which, according to lots of research out there, there's really no risk. Now, as a caveat here, I'll tell you, there's also published literature that says that there might be evidence of carcinogenic effects for acute radiation doses less than 100 millisieverts. So the science here is not 100% clear at the moment, but you can kind of just read through those two statements. That 100 millisievert, 100 milligray is sort of like a line in the sand. And what the majority of the literature says today, that anything below those numbers is very, very safe. So if we're already at a number much, much lower than 100 milligray, then why would a shield be necessary? That essentially is the question that the AAPM is asking, and the reason why they have suggested we no longer shield in many indications. We're going to talk about that tonight. Now, on the other side of the argument, you may say, well, what about ALARA, right? That's where we started. Isn't it our job to reduce dose to the lowest possible amount, right? That's what ALARA tells us, and that's what we're taught in our radiography programs, and hopefully that's what we're practicing. So any dose, no matter how small, carries some degree of risk, right? So why wouldn't we want to limit that dose to the smallest amount possible? And one of the ways that we can do that is to use a shield. So this has been a really controversial issue, obviously. Still nearly 4 years later, there's lots of consternation and confusion about it. And I think also a lot of inconsistency. And I'm even seeing that played out in the comments that y'all are adding to the chat. So keep those coming. Those are great. But you can see how we've all had very different experiences in when and where shielding is being applied at various institutions. Okay, so also important to point out a couple of things about that LNT. Remember that, the linear non-threshold theory? There's a growing body of science that does not support that theory, right? And this is where we get that number, that line in the sand of 100 millisieverts. A lot of scientists are saying the LNT is being inappropriately applied to medical radiation, that there really is very little risk of stochastic That's a word that means left to chance or probability, probabilistic. Things like cancer and genetic effects, the stochastic effects. The LNT is not really being properly applied to medical radiation exposure. There's even other scientists that are actually saying now that exposure to low amounts of ionizing radiation could have a positive effect, something known as a hormetic effect or radiation hormesis, that exposure to low levels of radiation actually improve the body's defense mechanisms and make those defense mechanisms stronger, just as if you work out with weights and break down muscle tissue, it comes back bigger and stronger. That's called radiation hormesis. So again, there's a lot of very confusing science. I don't have the answers. I'm just pointing out that the jury's still out, so to speak, about the risks of exposure to low levels of ionizing radiation. Okay, so let's do a little exercise. The other thing that the AAPM is saying to us as a basis for their proposed change here is that dose exposure, I should say, for our procedures or radiographic procedures has come way, way down over the last 60 plus years. These are some statistics on the screen that are widely cited as a support for this change in practice. If you look in 1959, you'll see some absorbed doses there for both male and female pediatric patients. Look what's happened by 2012. We're seeing a reduction in dose of nearly 96% over that time, and it keeps going down. Those absorbed doses are certainly even lower now, 10 plus years later. And there's a whole host of reasons for this, everything from the way the X-ray tube is filtered to the radiosensitivity of our image receptors, right? How sensitive they are to incoming radiation. We're able to produce spectacular radiographs with a very low exposure. And as technology continues to advance, that will likely continue as well. So long story short, we're seeing much less exposure and dose from our procedures, also adding to this idea that perhaps shielding is not necessary. Okay, so let's take a look at this with me, because I think it's also important, to be informed and to understand as a student and as a technologist, what risk from our procedures really means and what that looks like with real numbers. So here's an example of me. I'm 55, and imagine that you have just done an AP pelvic radiograph on me. And if you look at some data online, you'll see that perhaps an average effective dose would be about 0.6 millisieverts. So there's a really cool little online calculator at xrayrisk.com that you can go there anytime. If you know the effective dose of a particular procedure, you're able to plug in some demographic information about the patient, maybe even about yourself, to calculate your risk. So I did that for an effective dose of 0.6 millisieverts. And what the calculator told me is that gave me an additional cancer risk of 0.0027%. That wording is really important. As a 55-year-old male, unfortunately, I already have a pretty significant risk of developing a malignancy, right? There is an additional cancer risk from that AP pelvic radiograph. And I look at that number and I don't want any additional cancer risk, right? I'm sure none of us do. But the number is pretty small, 0.0027%. My baseline cancer risk is pretty high, right? At 55 years of age, nearly 45%. That's a startlingly big number, right? But in order to really get at the heart of how risky, I should say, that AP pelvic radiograph is, you have to add those two numbers together. And when you do, it kind of changes the perspective, right? When it was just 0.0027%, I'm thinking, well, give me a shield maybe, and let's get that number down even further. But when you add it to my already very high baseline cancer risk, the number doesn't seem to be as worrisome, I guess I should say. So again, really important to understand that the risk of our procedures is already very, very low. So kind of to summarize the AAPM's position and the position of many organizations right now, here's the argument against shielding. Right? I've kind of touched on most of this already today. Very low dose. Third bullet there is interesting. Shielding has little to no benefit. Right? So we saw that there is some benefit. But again, the concept there is we're taking an already very low dose and just making it lower. And those doses are already far below the line at which we feel is worrisome. Shielding has inherent risks of its own. I want you guys thinking out there, what are some inherent risks of shielding? And if you have a good idea, throw it in the chat. How can shielding be risky? Radiophobia exists in our patients and in the public at large. So that's an argument against shielding from some camps, that we are exacerbating radiophobia, this fear, unwarranted fear of medical radiation, by shielding our patients. The idea there is that if we stop shielding, that actually can help patients be less anxious and worried about our procedures. So again, just a quick overview of the current argument against shielding. And thank you for the comments. We'll touch on some of these as we go through, but yeah, it might cause a repeat, might cover up anatomy. The backscatter radiation due to shielding is an interesting one. And maybe I'll hold off to the end for that. But there is really very little evidence that shielding causes significant backscatter or traps X-ray photons in the patient. I'm fearful that some of y'all have heard that from technologists, and I'll just be blunt, it's wrong. Shielding is made of lead, and that lead, due to the photoelectric absorption interaction between photons and matter, that lead shield absorbs X-rays. X-rays don't bounce back into the patient. There may be some very limited backscatter, but it is insignificant in every study that has looked at it. So we don't have to worry about shielding trapping radiation inside the patient. But thank you very much for that comment. All right, so let's go back to the beginning. Take a sip of tea. This is the statement that came to us from the American Association of Physicists in Medicine way back again now in April 2019. A couple of key areas, right? Patient gonadal and fetal shielding during X-ray-based diagnostic imaging should be discontinued. Now, X-ray-based diagnostic imaging, that's a pretty broad statement. What does that include? It includes a lot. That last statement, the use of such shielding should be discontinued. Again, pretty general wording, right? Basically saying that for the most part, all shielding should be discontinued. Now they start off at the top with patient gonadal and fetal shielding. But again, the statements are awfully broad from the AAPM, which was part of the concern that folks had, including me. Basically, what people interpreted this as is that we are not going to be shielding patients at all, ever. And from the comments some of y'all put in the chat, that is certainly playing out at many institutions across the country. Okay, so again, the AAPM's rationale. We touched on a lot of this as well, so I'll go through it quickly. Shielding provides very little benefit. Current dose levels are very, very low, far below a level at which we might be concerned. And another interesting point, kind of related to the comment we had before about backscatter, is that when we place a shield on the surface of a patient, it doesn't protect that patient against internal scatter. Right? It doesn't reflect the scatter back into the patient, but there is scattered photons that travel within the patient. And if they're not absorbed by the lead shield, the shield is not really reducing that dose. And those statements are certainly very true. Number two, the use of gonadal and fetal shielding can negatively affect the efficacy of the exam. So we touched on that, and y'all put some really good comments in the chat. Yeah, we can cover up important anatomy. And I would think that's probably the best, most sound reason for not shielding within the exposed field of view, right? Within your collimated field. Again, back when I was a student and a younger technologist, we would put lead shielding in the exposed field all the time. I showed you that cup shield before, but I used to, when I was a student, and we had to do comps, just like you all have to do, we sometimes did them in the lab. And I remember being required during an AP pelvis or bilateral hip radiograph of a female patient that we actually were given small leaded circular pieces of rubber. Yeah, maybe the size of bigger than a quarter, more like a silver dollar, pretty big. And we'd have two of those. And in order to pass the comp, we would have to guess where the patient's ovaries were and place those two small circles somewhere on their pelvis. Now, I had no idea where the ovaries were, but that was pretty standard practice, at least as a student who was being educated and trained in the field. But we most definitely tried to shield the male gonads for exams like a KUB. So it was pretty common practice not that long ago. But that shielding certainly does obscure anatomy, and it can lead to repeats. So that is most certainly a true statement. This next one is interesting too, that shielding can interfere with automatic exposure control, leading to an inadvertent increase in patient dose. Definitely true. But of course, that's only if the shield is within the exposed field, right? And my question to you, is anyone doing this? So when was the last time you took a lead shield and put it within the exposed field on purpose? Probably haven't. So this is not common practice any longer, and it hasn't been for a very long time. There are some studies, mostly from other countries, that have demonstrated that improper shield position covering anatomy can lead to repeats or to misdiagnoses. There's also a handful of studies that talk about the potential for shielding to increase dose when we're using AEC. But those are, for the most part, phantom studies demonstrating that dose would certainly increase if you put a lead shield over an ionization chamber. But I think we know that, which is the reason why we don't put lead shields over ionization chambers. And I know you all know that as well. Nevertheless, after the April 2019 statement by the AAPM, lots of organizations quickly endorsed that statement. Initially, the ASRT was not one of them, and we'll talk a little bit about that this evening. But again, this change in practice was widely accepted all across the country. It received some pretty significant media coverage at the time. You can kind of see the headlines there from some pretty big media outlets. This is actually good because part of the issue we're going to talk about tonight is the fact that our patients may not be aware of the rationale behind this change in shielding practice. Right? So they come to our exams, they come to you all expecting to be shielded because that's what happened the last time they had a procedure. So re-educating the public at large and our patients about this change is very, very important. We don't want patients to come to us and think we just forgot to give them a shield, which is a pretty natural thing to think, I think, when you're a patient. So this type of education is really, really important. And what I'm going to show you a little bit later is efforts by the ASRT to continue this patient education about the safety of our procedures. But it was a pretty big deal at the time. And that was, again, April of 2019 and later on through that summer and fall. If we fast forward to January of 2021, the National Council on Radiation Protection and Measurements put forth a statement that we see here on the screen. And what's really important to keep in mind, it's the NCRP in this country that really dictates and it is the authority on radiation protection efforts. Okay, the AAPM is important and is a very, very sound and respected group, but we really take our marching orders, so to speak, with radiation protection from the NCRP. And in 2021, the first few days of 2021, the NCRP agrees and recommends that gonadal shielding not be routinely used. But I want you to take notice at the language that they've selected here. It is very specific, right? So gonadal shielding is not to be used routinely during abdominal and pelvic radiography. Not all tests involving ionizing radiation, right? Only during abdominal and pelvic radiography. So this really is the definitive statement that the ASRT was waiting for, and our board quickly jumped into action at the time. Again, this is January of 2021, and we put forth a couple of statements. Let me just blow up what's important here in this box. So consistent with our commitment to a culture of radiation safety, it is the ASRT board's position that it is appropriate to discontinue shielding for abdominal and pelvic imaging. Notice that last portion of the statement, when the exam is performed by a registered radiologic technologist. We also want to stress that, right? We are the individuals with the skills and the know-how to properly implement this change in shielding practice, and only us. That was the first statement, right after the NCRP statement. We followed it up quickly just a couple of days later with a second statement. Again, the important part is in this yellow box. So our board and the ASRT supports the continued use of lead shielding when that shield placement is appropriate and helping us to minimize patient radiation exposure. So we provide an example there. Think about the exams that you do. Pediatric patient comes in for an upper extremity radiograph. They're seated in a chair, the side of the table. They're placing their hand, let's say, over the image receptor. We feel that it is still an appropriate practice to provide them with a lap shield. And that, in a sense, is the ASRT position, which we can summarize here as well. So we feel that patient shielding remains an acceptable practice as long as it does not lead to a repeat. Of course, that's the last thing any of us want to do. Can't have the shield obscure pertinent anatomy, right? Which is, again, the reason why we're not going to place the shield in the exposed field. And by making sure we don't, of course, we're not going to cause the AEC to malfunction and inadvertently overexpose the patient. So most definitively, every organization is aligned with the statement you see there in red and highlighted in yellow. Fetal and gonadal shielding should not be employed during abdominal pelvic radiography. So moving forward, that should be our shielding approach or patient shielding approach. I'll stop there for a second to see if there's any questions in the chat, because I know I've been rambling on and lecturing on, but everybody doing okay? Questions at this point? Okay, we'll keep going on, but please stop me at any point. So I've titled this slide, words matter, and I think they do. And again, part of the issue here all along has been not so much the science of this proposed change in practice, but the way it has been communicated to us and to patients, and the way that it has been implemented. Now, draw your attention. This is a very famous publication that has quite a large number of citations at this point. But just take a look at some of the wording that's used here. Referring to patient shielding as folly, and that it's important for us to be part of the individuals that abandon the practice of patient shielding in radiology. Again, very, very general language, right? Radiology is not radiography of the abdomen and pelvis. Right? The term radiology is a much larger term, and that's, I think, of issue in this. That we've just gone maybe perhaps a bit too far too soon. So let's talk about that next. Question we have before us, what are we eliminating? Is it just shielding the gonads during abdominal pelvic radiography, or all shielding in radiology, right? And this is part of the issue really over the past 3+ years, the confusion surrounding this, that technologists don't fully understand what it is exactly they're supposed to be stopping, right? So hopefully we're going to work together tonight to make sure moving forward, everyone here tonight understands very clearly. So again, we started off tonight talking about the LNT for a reason. And I'll remind you of it one more time, right? If it's our job to limit exposure to the lowest possible amount, then how can we eliminate shielding? Right? So just sort of big picture questions. The thing that I think I find most interesting, because I'm an educator and really most concerning at the same time, is that I understand that radiophobia is a thing for sure. And I haven't done a radiograph clinically in a very long time, but I'm sure you all in your training so far, those of you that are doing clinical, have probably had conversations with patients about their concerns about radiation exposure, right? So patients come in and say, is this test going to give me cancer? Am I going to glow after this? All the funny, kooky things that patients can say, right? That's radiophobia. The night before their procedure, they've Googled the procedure that they're having. And you all should try doing that, because there's some pretty wacky stuff out there about the dangers of medical radiation exposure. And that's what our patients are seeing. So of course they're coming in concerned. But as an educator, I'm not sure that simply ceasing to shield them is the best way to reduce that radiophobia. And I have that image of the cart before the horse there, because that's the saying, right? Are we putting the cart before the horse, when perhaps a better approach would be to educate the public and our patients first, and then remove the shields, right? So to me, it's not good teaching technique simply to remove something in the hopes that our patients are going to connect the dots into thinking that our procedures are so safe that they don't need shields anymore. I think we should tell them that, and tell them that clearly. The other thing that's a concern is, the part of the reason for eliminating shielding according to the AEPM, is because of the risk that that shielding entails. But, we know what we're doing. We're highly skilled, part of an autonomous profession. Is there really any risk here in placing a shield, as you see on this young gentleman's pelvis, for knee x-ray or whatever lower extremity x-ray is being performed there? There's no risk. Right? So important questions to think about. To sort of wrap up this little section of our talk tonight, it's also really important to consider shielding from what I would call a customer service perspective. And again, our patients are coming to us and trusting their care to us, to our expertise. And the proper use of shielding is something they've come to expect, particularly when you are working with pediatric patients and their parents are there. Right? They are fully expecting that their son or daughter, that patient is going to be shielded. So again, in order to combat radiophobia, I think we need to have a very proactive and deliberate approach as far as education. And that really is key. One last thing, and it's just food for thought. And I don't mean to sound like, the kind of person that thinks the sky is falling, but I want us to consider something else that I think is pretty important. How a move like this can potentially impact our practice moving forward. Right? So the questions I'll ask here: if the dose is so low for the procedures that we do, and if our procedures are so safe, they are so safe, in fact, that there is no risk, then couldn't anyone perform them? Why do you need us? Why isn't our team needed? Now, I'm not suggesting that we act as if our procedures are more dangerous than they are, right? Or dramatize the work that we do just to make ourselves seem important. But I think it is very important for us to kind of take the lead in radiation protection efforts. The reason why our exams are so safe is because of us, not just the technology, right? And that safety goes out the window, perhaps, if there's not a skilled, credentialed radiographer at the exposure button for a radiographic procedure. And that's a really important concept that we need to keep at the forefront of this issue and many others moving forward. I know students, you're out there and you have a lot of technologists who are constantly telling you that things don't matter. What I mean by that is, you're out doing portables, and I'm going to guess that you've seen technologists not wear a lead apron, during a portable. I'm hoping you're not doing that, but I know it's happening with students in my own program. You're told things like collimation doesn't matter, and focal spot size doesn't matter, and contrast doesn't matter. How many times in a given day do you hear something from someone about something not mattering? And that really has to stop, right? Because all of it does matter, and we matter in the sort of the chain that leads to safe, effective procedures. And that's really what we need to be saying. But first, we got to say it to each other. These things matter. So just again, food for thought. Most important message out of all of this is what's on the screen, right? Again, safety of our procedures is because of us, and that is the most key point that I want to kind of leave you with tonight to make sure you're helping sort of cheerlead this moving forward with the technologists you're working with and with each other. So what can we do now? There's a couple of educators on the line with us tonight, which is great. We certainly want to continue to teach about shielding. Right. So we'll look later, the patient shielding has been removed from the content specifications for the radiography exam. And I'll talk to you about that a bit in just a few minutes. But that doesn't mean we shouldn't be teaching it. If we're not teaching our students how to properly shield, when and how, they're never going to learn it. So as educators, we need to continue to teach about shielding. To the students out there and the RTs, you want to, as your facility permits, continue to shield. Right? And by all means, you do not want to stop occupational shielding. Again, you're out there doing portables, and you're working alongside other healthcare practitioners. Let's pick on nurses for a second, not to pick on, but that's who's around when you're up in ICU doing a portable, right? What kind of message are we sending to our colleagues in other areas of allied health when we don't shield? someone's going to start to ask the question is, why did an RT have to come up here and do this portable if, again, the portable is so safe that we don't even have to shield anymore? So important concerns and considerations to make. And then for all of us, let's talk a little bit about the ASRT Patient Shielding Task Force, because we are here to help. So very excited about this initiative. We started it almost a year ago. I had the opportunity to be a part of that, working along with our vice chair, the current chair of the board, Dr. Christy Moore. And there's a group of members there that you see, then probably will recognize some of those names. These are very accomplished, highly skilled folks in our field from across the country and representing lots of different modalities. You see them in parentheses next to their names. So we got together to do a couple of really important things. And you can kind of see the purpose and goals here on the screen. We wanted to design and disseminate materials to help technologists, to help educators, and to help students, first and foremost. But secondly, and probably even more importantly, we want to educate the patients and the public at large about the safety of our procedures, right? So education first, and then removing the shields. And we approached this with a very specific concept, and you see that here on the screen. So what we're basically saying is that it is the RT that embodies the shield. We are the patient's best protection, best radiation protection during their procedures, right? So I'm going to show you a video in just a second, but I want to ask you just to kind of listen to the language of the narration, because this is a very important focus for us. Again, safety is not a given, right? It's predicated on the fact that we are at the helm of our systems. So over the past few months, the task force has been able to do a couple of things. Let me just come back here. Sorry. In the November-December issue, we published a special report in the journal, Radiologic Technology. So if you have a chance to take a look at that, perhaps it's lying around in your program classroom, or hopefully a lot of you are ASRT members and have received a copy of this, maybe online, please take a look at it. But what I'm really excited to remind you of is our new webpage. So asrt.org/shielding. And there's tons of materials on the website for you all to look at. On the upper right-hand corner, you see the gonadal and fetal shielding. That's a poster, and you can download it in PDF form and print it in various sizes. But there's lots of really good information on the website. So please, when you get a chance, take a look at it. One of the things that's on the website are a couple of videos. There's a video that's designed to educate patients. We're going to take a look at that here in just a second. And there's also a slightly longer video that's designed to educate students and technologists. So please when you get a chance, take a look online at the technologist video. I'm going to show you the patient one tonight because it's shorter, and help us spread the word about these resources. I think they can be really valuable. All right, let's take a look.
During your exam today that the radiologic technologist, the professional who is performing your exam, may not place lead shielding on you. While you may have had lead shielding placed on you for imaging in the past, there is nothing to worry about. Professional societies, including the American Society of Radiologic Technologists, have worked with scientists to determine that lead shields should not be used in imaging if the shield could hide important details or interfere with the exam. Because lead shields block X-rays, anything covered by the shield can't be seen on radiographic images. Exams that focus on the pelvis and abdomen no longer need lead shields because the radiation risk is very low, and it is more important to see everything in this area. The imaging equipment we use today is much better than older equipment, and most of our exams are performed using a very low amount of radiation. Instead of shielding during all exams, radiologic technologists use other techniques to ensure that your exposure to radiation is kept to a minimum while still capturing high-quality images. For a few procedures, we still use shields to further reduce your exposure to radiation. Your best shield during imaging is the radiologic technologist, a highly trained professional who knows all the latest techniques for keeping you safe and reducing radiation dose while capturing high-quality images. Their skills, combined with modern technology, result in very safe and low-dose imaging procedures. If you have any questions, feel free to ask the radiologic technologist who is performing your exam today. We are here for your safety and to ensure you receive a quality exam. Don't worry, radiologic technologists have you covered.
All right, thanks for bearing with me and watching that. So what do y'all think? I get choked up still sometimes when I see that video. I love it so much. But I think it sends a really, really good message to our patients. The idea of it is perhaps we're hoping that facilities will play it in waiting rooms, right, as a way of educating patients sort of on site. But again, please help us spread the word about it. Take a look at the technologist video as well. These are really important resources. All right, let's see, got just a few more minutes. We would love your help. So if you have questions, concerns, really you want to just send along comments, shielding@asrt.org is the address, the email address for our task force. And that comes right to our inbox. I monitor that along with Dr. Christy Moore, and we respond as immediately as we can. So please, at any point, reach out to us. And we'd love to hear what's going on where you're working and to be of any help that we can. So email us, shielding@asrt.org. All right, and just over the past few days, there's one last thing I want to kind of talk to you about because it's sort of hot off the presses. You might hear technologists talk about a change from the FDA. So without boring you terribly with all the details here, there's something known as the Federal Register. And if you are ever having difficulty sleeping, Google Federal Register, and you will see tens of thousands of web pages describing pretty much every process, procedure, law, guideline for every industry in the United States. This is actually a thing that exists called the Federal Register from our government. There's always been a section of the Federal Register that applies to medical imaging. It's a small section, but it's monitored and controlled by the Food and Drug Administration, the FDA. And just a few days ago, 6 days ago, in fact, a new recommendation, a change was approved in the Federal Register. So what you see there on the screen right now, section 1000.50, yada, yada, right? Everybody sees that? In quotes, you see the gonads, or actually shielding should be used when the gonads will lie within the primary X-ray field or within close proximity about 5 centimeters. That's the rule that I learned as a student in 1987, a long time ago. And it's been, in a sense, the rule ever since, right? So the FDA told us that if the gonads are close to the field, right? So again, the male gonads during a KUB, the female gonads during a KUB, right? They lie within the primary X-ray field. According to the FDA, those gonads should have been shielded. Well, just a few days ago, they have completely removed this section of the Federal Register, right? And it made some pretty big news in the profession, like on Aunt Minnie and some of the trade papers, things like that. But what's really important for everyone to keep in mind is that this is really not that big of a news story, because again, the Federal Register never mentioned the type of shielding that we're recommending. We're not talking about shielding the gonads when they're in or near the field, right? So this removal of this language is in good alignment with, again, that concept that every organization agrees upon, that we should not be placing a shield within the exposed field of view. Right. So what I've heard recently as well, even the FDA has said we shouldn't shield any longer. No, that's not the case. The FDA, the Federal Register, never had any language about placing a lap shield on a pediatric patient for an upper extremity radiograph. That information is not in the Federal Register and it has not been removed because it was never there. So this is a small change, an important one for us all to keep in mind. But I just wanted to kind of mention that just in case you're hearing something about the FDA when you're working with technologists. All right, of more importance probably to you all is the ART and its handling of shielding. So it's important to keep in mind that, the American Registry of Radiologic Technologists does a really good job with the help of technologists and educators of producing very valid multiple choice questions for the exam. And it's really important for the ART to always keep in mind that this is a big country and every student is taking the same exam or a version of the same exam. And the content needs to be very consistent and it needs to be applicable to all students. Because of the controversy surrounding shielding and because of this recommended change, the ART has removed mention of shielding as far as patients. So on the left, you'll see what a section of the content specifications a few years ago included, if you look at radiation protection in the yellow box, shielding, rationale for use, types of shields, where they should be placed. That information has been removed on the 2022 version of the content specifications. So long story short, you should not see any questions about or related to patient shielding on your credentialing exam. Will you see questions about occupational dose reduction using shielding? Yes, and on the lower right-hand corner of this slide, you'll see I have that highlighted in yellow. Shielding is most definitely still a method of protection for occupational exposure. So important to keep in mind. So that's shielding in the ART. All right, so a couple of conclusions before we run out of time. Certainly the science around radiation dose and risk is most definitely changing. I know sometimes I hear from folks that the ASRT doesn't agree with the AAPM. That's not really necessarily true. That's not the whole story. The ASRT is certainly in alignment with the other organizations in that we should not be shielding the fetus and or the gonads in the exposed field, right? Particularly during, of course, abdominal pelvic radiography. But we do feel that shielding remains a best practice when it's appropriate. Absolutely, of course, we should be shielding ourselves during all appropriate and applicable procedures. That should not stop. And of course, the ASRT Patient Shielding Task Force is here to help with all of this. So this has been, again, a very interesting time in our field. And, whenever there's a change that's this big, it can get a bit controversial, and this has been no exception to that. But one thing has not changed, and that is what you see up here on the screen. Our patients, your patients, deserve the very best service that we can provide. They need us to be radiation health experts, right? Us, RTs. So as you're working through your program, this should really be a focus of your work. If we're not the radiation health experts that are going to assist our patients and make sure they understand this change in practice, make sure they remain very confident in our care, if we're not radiation health experts positioned in a way that we can communicate effectively with patients, who's going to, right? When was the last time your patients that you've been working with have had a chance to talk to the radiologist, or much less a physicist? That is very rarely going to happen. But we are speaking to every patient, right? They are entrusting their care to us. And it's really important for us to be experts and informed on things like shielding, right? So we can engage in really meaningful and appropriate conversations with them. And so that we can produce fantastic images, which is what it's all about. So with that, I'll stop rambling on and see if there are any more questions out there. I'm going to bring up the chat, bring it back into my primary view here.
Hey, Dan, I have one comment. This is Christy.
Hey.
So all of you students understand that the state of California, Title 17, actually has it in there that we are to shield as long as it's not obscuring anatomy. So within California state law, Title 17, we are to still shield. So it is important to make note of that.
Christy, do you know if there's been any move to revise that?
Nope. None. I haven't seen, I've been watching and I haven't seen anything come across as far as removing that. So I'm kind of surprised. I've been watching to see, I'm on the, advocacy side. So
Sure.
Nothing's come.
Well,
so far, so good.
And this is not a criticism at all, but I mean, California certainly takes a very cautious approach to things like this. I mean, just look even what's happened with fluoroscopy in your state. So you really are the leaders in maintaining or maximizing patient safety, I guess I should say. So maybe it's not coming, California.
Yeah, I don't know. We'll see. So it is important. I did talk to, the state of California about this issue and saying, hey, some of our huge healthcare systems are not shielding anyone. And they said, yeah, we're not going to fine them, but we will tell them that this is law and you need to do this, although we're not giving any, penalties. I'm like, well, what good is that?
Well,
It's interesting.
yeah. If anything changes, I would love to hear about that, Christy. If you
Yeah,
do.
I'm watching.
Okay, awesome. Carl's got a good question up here as far as, this idea of causing the AEC to malfunction, right? Again, if you haven't yet learned about automatic exposure control and sort of the technology behind it, there are ionization chambers, devices that measure incoming radiation and then send a signal to the control panel, so to speak, to terminate the exposure once a sufficient exposure has occurred. And that's the way automatic exposure control works. But automatic exposure control is dumb. It's not smart technology. You're smart, right? The technology is not. So when you place a lead apron over that ionization chamber, it does not know that it's a lead apron. It only knows that it's not receiving enough radiation, and then will allow the exposure to continue until the ionization chamber does receive sufficient exposure, right? So it doesn't know what's patient, what's shielding, doesn't know anything. You do. So when we place a lead apron over that AEC cell, we can have a pretty significant increase in patient exposure. But as long as the shielding is maintained outside of the exposed field and is not overlying the AEC system, that shielding remains very, is very safe and will not cause an overexposure. So thanks, Carl, for that question. So, yeah, shielding geriatric patients. I mean, this used to be my approach, and what I was primarily was a CT tech. So I'll give you an example. Even when a female patient came in for a CT, it was common to say, is there any chance you may be pregnant? And I'm sure that's common practice for many of you during radiography. I used to ask that question to everyone. Anyone of childbearing age, certainly, as far as teenage age, but older women, 50, 60, 70, I would ask the question anyway. And, I'd get a chuckle, usually it would wind up being like a little joke, but I guess I didn't discriminate with regard to age. And I suggest to students that they follow the same policy with shielding. And here's sort of a little thought exercise. I've heard some facilities say, we don't shield anybody over 50. So, the way my mind works, well, does that mean like yesterday, if I was 49, I would have gotten a shield, but today, because it's my birthday and I'm 50, you're not going to shield me anymore? Like, what is with that arbitrary cutoff? But the bigger question I'd have you ask yourself is, if it's your mom or your aunt or your older sister and she's 52, are you going to give her a shield? Probably. So if it's good enough for your mom or your aunt or your sister, it's good enough for the patient. So I think there's not a definitive age at which I would say to not shield. You just have to use your judgment. You have to use your judgment. You want to make sure for sure that the shield is not going to cause any discomfort to someone who's older. And that's the consideration. But I think, is that shield necessarily reducing the individual's risk when they're 70 or 80? Probably not. But again, we should be consistently providing the best care possible to all of our patients, regardless of their age. So I hope that kind of answers your question. And thank you, Tina. Janet Jackson had a kid at 50. I didn't know that, but God bless her. That's great. Other questions? I know it's been a long night and you guys just got home from clinical after battling traffic for a long day. All right, Sadie, Carrie, team, anything else?
Yeah, that was awesome. Oh, David has a question.
David, yeah, please.
Hi, can you hear me okay?
We can.
Okay. I had a pretty specific question, actually, that our professors wanted us to ask. Can a healthcare facility make it mandatory that certified technologists hold pediatrics during an exam if immobilization accessories are not available?
Oh. So I get the feeling that you're asking that question not as a hypothetical, which is fine. I don't need to know the name of the facility. I mean, I'd have to look at your state statutes. I mean, that is incredibly poor practice to mandate that technologists hold patients during a radiographic exposure. It's the technologist that always should be the last choice. Family members, even other healthcare professionals who are not exposed to radiation on a daily basis are a better choice than RTs. I guess if there's not something in your state statutes that forbids it, I mean, a facility can basically say anything that they want and hold their employees responsible for any regulation, but that doesn't make it right. So David, to answer your question, I'd have to kind of know a little bit more about what your state statutes say. I mean, there's no federal legislation or any laws on the books that prevent us from holding a patient. It's just not recommended practice for obvious reasons.
Understood. Thank you.
Ahead. No, you're welcome. I guess, the short answer is probably yes, they can do that, but that doesn't mean it's the right thing to do. Diane, yeah. Hi.
Hello, thank you. So there was another question that our professor wanted to ask. You basically wanted to see if there was any state or federal law that prevents pregnant mothers, if lead shielding is being utilized, from holding their child during an imaging exam.
No, there's not any federal law or legislation that would prevent that. What I have seen, and I've actually seen it here in Connecticut, is some states are pushing back on this with legislation, changes to state statutes that are requiring facilities to keep lead shielding on hand. And that's an interesting little wrinkle. They understand that this change in practice is pretty widespread. So folks are pushing back a bit and saying, well, that's fine, but we don't want this to result in a cost savings thing where facilities are no longer purchasing lead shields because they think shielding is not necessary. So I've seen that on a state by state basis, but to my knowledge, there's no, again, regulations against anyone holding a patient, including someone who's pregnant. That's certainly a circumstance where we need that person to be shielded. And what's really interesting about all of this, you guys are talking about, other people in the room, caregivers and so forth. When you look at the AEPM information, part of the thing that has really bugged me and some of us over the past few years is the AEPM was actually recommending that for a pediatric patient, you would not give them a shield. So let's say you have a 13-year-old on the table for pelvis and bilateral hips. That's a kid who is in a paper gown lying on a hard cold table, and their parent is in the room because he or she needs to be. According to the AEPM, you would actually give the parent a lead apron because they're in the room. And let's just say that's a 13-year-old female patient. You would not shield her breasts because shielding is not necessary, according to the AEPM. But they do tell us that we should give an apron to the parent. So if you were to ask a parent about how they'd feel about that, they're going to question it. Why are you giving me a lead apron and you're not giving my child a lead apron? That's sort of a very good example of the concern that we have with regard to service and customer service and patient satisfaction, which is important. We're in the service business. Here in Hartford, a large institution, Hartford Healthcare, their policy is we're not going to shield patients unless they refuse to consent to the exam. So in other words, we're not going to give them a shield, but if they make a really strong argument and then threaten to walk out, okay, then we'll give them a shield. And what I've said to those folks is, why do we want to put technologists in that position? Why would you? It's like a restaurant saying we're not going to give water anymore when our patrons sit down, unless they threaten to walk out. Then okay, we'll give them a glass of water. It's the same kind of analogy, same kind of angle. So there's been some interesting things that have happened across the country, but that's a great question. But again, no, not to my knowledge, is there any rule that prevents a pregnant patient from holding a patient? It's just not good form, as I said to David, not a good approach.
Right. Okay. No, thank you so much. There is actually one more question.
Yeah, shoot.
Can you also explain like what is the difference between the ALARA levels? Because you know how there's the 3 levels. Like, can you explain the differences between those 3?
ALARA levels?
Mm-hmm.
What have you been told? Yeah, I'm not familiar with levels of ALARA.
Well, I know from what we've been learning, there are
Mhm.
3 different levels of ALARA.
Yeah, that's not something I've heard about. So here's what I need. I mean, there's something in the comment as far as time, distance, and shielding. Those are 3
Mhm.
components of ALARA. Is that what you're asking, Diane?
Uh,
I don't think so. I think you're speaking of something else, but I am not familiar with it. So here's what I'm going to ask. You see my
Mhm.
email address? DeMaio at
Yes.
harvard.edu. Can you shoot me an email? Because
Yes, of course.
about it, because I would be very interested in learning more about what y'all are discussing as far as levels of ALARA. That is not
Yes.
something I'm familiar with.
There's actually a sheet. I don't have it pulled up right now, but there is a sheet that we've been given that gives like the 3 levels of ALARA. So
Oh, I would love to
I
see that.
can send that to you and then,
Please.
you know, kind of go from there.
Yeah, please do. And I'll send, we'll have a chat about it, and then I'll follow up, maybe send it to, Carrie or Sadie, the end result of that discussion, and they can disseminate that information to all of you. Okay.
Great. That
Yeah, you
sounds
stumped me on
wonderful.
that one. I love it. I definitely want to see that.
Okay, I'll send it to you right now. Thank you.
Awesome. No, you're welcome. All right. Anything else?
It looks like you have a question from Jacqueline in the chat.
Oh, thank you. Someone told me shielding is better because it doesn't do much, because when the X-ray hits the IR, it shoots right back. So shielding. Well, sure, Jacqueline. I mean, that's not one of the reasons why the AAPM has recommended we no longer shield. I can say that. But for the longest time, there's been a concern about backscatter. So much so that for a short period of time, or a few years, it became sort of like trendy. Some technologists were shielding the anterior surface of the patient for a PA chest. So you guys have all done PA chest. Put your imagination caps on and think about the patient positioned up against the upright image receptor for a PA chest. Normally, let's say if you're going to use like a half apron, you would wrap the half apron around the patient's posterior surface, right, to shield primary radiation or all focus radiation. For a while, it became somewhat fashionable to slide the shield around so it was on the patient's anterior surface, with the idea that you'd be shielding radiation that scatters back from the image receptor. Empirically, that was demonstrated to significant reduced dose, but not as significant as putting the shield where we were originally taught, which was on the posterior portion of the patient. So it's kind of fallen out of favor now. But as far as your specific question, Jacqueline, that's not really part of it. You bring up a good point. Sometimes we tend to think or assume that the image receptor captures all of the radiation. And I think when you're first learning this, that's just a logical thing to think of, right? But what I always remind students of, that X-ray was capable of passing through a patient who may be 300, 400, 500 pounds. It is certainly capable of passing right through the image receptor. And some of those X-rays could also scatter back. But that's not reason to not shield. So that's the simplest way I can answer that question, Jacqueline. There is concern that shielding is becoming obsolete for some of the reasons we talked about tonight, but that's not one of the reasons, at least to my knowledge. I'm going to slide down because I think there may be some questions. Minu, you have a question?
Hi, yeah, I have a question. Can you hear me? I'm
Yes.
sorry.
Hi.
So when it comes to pediatric X-ray, there's like, for example, if you're doing their chest X-ray, they're laying on the bed, but we have to cover their gonadal shielding, which makes sense, like the gonadal area. but if you know that's causing like a lot of motion because the kid is kicking it around, they don't want it on them. So would you say it's okay not to shield at that point because you don't want to do repeats?
Yeah, absolutely. I
Okay.
mean, from the standpoint of radiation protection, the most important thing is to not produce the image twice, not acquire the image twice, and expose the patient twice. So anything that has the potential to cause a repeat, we should avoid. Okay, the
Thank
shield,
you.
yeah, the shield itself is going to do very little in that instance. So if it's causing the patient to move because they don't want it on them, then don't use it. That would be my recommendation. But great question. This
Do
has
we
been
have
great.
any others? Yeah, this
Yeah.
is awesome.
Thank
I'll
you for your
ask you one
question.
thing, Dan.
Yeah, please.
Well, I'm in California, so we have to shield. But as students, do you recommend us stepping up and trying to implement this change, or waiting until we're technologists because we don't want to overstep anyone?
I can tell you what I've told our students, and it's the same old thing we tell our students this a lot. Your guests at the facility. So you are to follow the facility's policy and procedures. And sometimes in life, especially in this type of clinical training, you learn what to do, and that's very important. But I think you would all admit that you've observed some things, perhaps clinically, that you're learning what not to do as well. And that's an important lesson. So if you're seeing processes, activities that you don't agree with, good. It's not good that they're happening, but that's great that you're identifying that these are things that you're not going to do, and you're not going to teach future students to do,
Right.
years from now. So to answer your question, you got to follow the policy of the institute.
Okay.
Okay.
That's
Okay.
fair. Do we have any other final questions? Give me a minute. I'm not seeing anything pop up. Dan, you've been super informative. I love the video and how there's a little bit of a pun at the end that we got you covered.
Great.
Appreciate that. Anyone else, questions, comments, concerns before we close? I want to respect Dan's time being awake so late.
Yeah. And
I just wanted to mention, I love how inclusive the video is also.
Yeah, it's awesome.
Diane sent me that plan, a radiation protection plan from her program. And Diane, the alarm levels that you're speaking of are not like standardized levels. I think this is something that is sort of proprietary to your college and maybe to the clinical institutions that you're affiliated with. And what they are, everyone, are levels of dosimeter readings. And they've titled them ALARA level 1, ALARA level 2, but they're just using the acronym to describe the levels of dosimeter readings that are allowable for different folks, students versus technologists, that sort of thing. So it's an innovative way to title them, but that's not really a widely accepted concept. It's just something I think unique to your school and to your hospital, which is great. I'm gonna take a look at it more carefully, and I may steal it. So thank you.
No problem. Thank you so much.
Right. You're welcome. All right. Well, thanks everyone. Really was a pleasure to be here, and congratulations again to your student committee. I mean, just fabulous, fabulous work. Very proud of you all, and looking forward to seeing what you're going to do next. I know you're going to be leaders in our profession, which is so exciting.
And thank you, Dan.
Thank you so much, Dan.
Okay. Good work, guys.
We
Be safe.
appreciate it. Awesome.
Okay. Have a good night.